Welcome to the Deep Dive. We're here to give you the essential knowledge you need, fast, cutting through all the noise. Today, we're plunging into, well, one of the most dynamic experiences in healthcare: labor, birth, pain control, and fetal monitoring. It's a big one. Okay, let's unpack this. For you, our nursing students heading into OB, this deep dive, it's all about arming you with that critical physiologic knowledge and the evidence-based interventions you'll need to support clients through childbirth. Our mission is really to help you feel confident spotting when action is needed, when to collaborate with the team. By the end, you should feel well prepared to integrate all this, promoting safe, positive outcomes for mom and baby both. Ready? Let's jump in. When we talk about birth, it's easy just to focus on the baby arriving, but the whole process, it's like this incredible symphony of changes. Understanding these changes, maternal and fetal, it's not just like interesting trivia, it's absolutely fundamental for the nursing care you'll provide. So what's really remarkable about how the mother's body actually gears up for this?
It's truly fascinating. So many systems don't just adapt, they actively prepare for this huge physiologic event, even potential blood loss. It's incredibly coordinated. Take the reproductive system. Those labor contractions, they aren't random spasms. They're coordinated, strongest at the top, the fundus pushing downwards. They're involuntary. The client can't just decide to stop them, though movement and relaxation definitely help manage them. And critically, they're intermittent.
Intermittent. Okay, why is that so important?
Because those rest periods between contractions, that's prime time for placental blood flow. It's when the baby gets its oxygen and nutrients. It's absolutely crucial.
Okay, so when we're assessing contractions, frequency, duration, intensity, what else?
The resting tone. That's a key nugget for you as nurses. Between contractions, the uterus must feel soft when you palpate it, if it stays firm or rigid.
That's bad news for oxygen exchange.
Exactly. Fetal gas exchange is compromised. Think of the uterus like this. The upper part contracts, pushing down, while the lower part and the cervix relax, thin out. That's effacement, measured in percent. And then the cervix dilates, opens up, all the way to 10 centimeters ideally.
And that happens differently for first-time moms versus others.
Yeah, typically. First-timers or nulliparas usually efface quite a bit before they start dilating significantly. Multips, those who've had babies before, often do both together more concurrently.
Got it. That resting tone point is huge. Okay, besides the uterus, what other big maternal system changes do we need to be watching really closely?
The cardiovascular system is definitely a big one. With each contraction, it pushes about 300 and 500 milliliters of blood back into the general circulation.
Wow, okay, so that affects vitals.
Absolutely. It temporarily bumps up the blood pressure and can slightly lower the pulse rate. So key nursing point. Check vitals between contractions to get an accurate baseline reading. And another critical tip, really emphasize this. Avoid having the client lie flat on their back, the supine position. Can really compress major vessels and decrease cardiac output.
Which impacts mom and baby.
Definitely. Always encourage side-lying positions. Left side is often preferred, but right side works too. It supports maternal circulation and helps fetal oxygenation.
Makes sense. What about breathing?
Respiratory system also adapts. Breathing tends to get deeper and faster, but, anxiety or pain can easily lead to hyperventilation.
Right, that dizziness, tingling.
Exactly. So your role there is to help coach them, help them slow their breathing, use relaxation techniques. Also, digestion slows right down. Nausea is pretty common. This increases the risk of aspiration if they were to need, say, emergency anesthesia. So the standard recommendation is clear fluids only, ice chips, maybe some broth, juice, popsicles, no solid food during active labor.
Good to know. And the bladder, you mentioned that earlier.
Yes, don't forget the urinary system. The sensation of needing to pee can be really reduced, especially if they have an epidural. And here's the clinical pearl.
Yeah.
A full bladder can physically block the baby's head from descending. It can actually impede labor progress.
Seriously, just a full bladder.
Yep. So nurses need to assess that regularly. Remind the client to try and void, assist them to the bathroom if possible, or anticipate the need for catheterization if they can't go. And finally, the hematopoietic system, the blood system. It's amazing, really. Blood volume increases during pregnancy and clotting factors go up, basically preparing the body for the normal blood loss of birth, which is usually around 500 to 1,000 milliwells.
So the body's ready.
It is, but keep in mind clients who are already anemic have less reserve to handle that loss. Also, a little heads up. White blood cell counts naturally rise in labor. It doesn't automatically mean infection.
It truly is a marvel how the mother's body prepares. But like you said, the baby isn't just passive. This is where it gets really interesting for me. What's happening from the fetal perspective during all this?
Exactly. The baby is an active participant. During contractions, yes, placental blood flow temporarily decreases,
Hmm.
but the fetus has some incredible built-in buffers. They have fetal hemoglobin, which carries more oxygen, higher overall hemoglobin and hematocrit levels, and a really high cardiac output relative to their size.
So they're generally okay with those dips in flow.
Generally, yes. However, and this is important, if the placenta is already compromised, maybe due to maternal issues like diabetes or hypertension or placental problems themselves, those fetuses might really struggle to tolerate the stress of contractions.
Okay, that makes sense. What about their heart rate?
The fetal cardiovascular system is constantly adapting. A normal fetal heart rate, or FHR, is typically between 110 and 160 beats per minute. Preterm babies often run a bit higher. And crucially, those little fluctuations you see in the heart rate on the monitor, that variability, that's generally a good sign. It signals the baby is tolerating labor well, their nervous system is intact and oxygenated,
And their lungs, they're filled with fluid,
and
right?
they are. But the process of labor itself helps prepare them for breathing air. The squeeze of contractions helps push some of that fluid out. Plus, stress hormones released during labor also aid in fluid absorption.
Ah, so that's why C-section babies without labor might have more trouble.
Exactly. Babies born by scheduled C-section without experiencing labor contractions are statistically more likely to have transient tachypnea, that rapid breathing, right after birth because they didn't get that natural squeeze.
Fascinating. Okay, so we have all these amazing maternal and fetal adaptations happening. How do we, as nurses, kind of put it all together to understand how labor is actually progressing? What's our mental model?
That's where the classic 5Ps come in. They are powers, passage, passenger, position, and psyche. Think of them as the 5 critical factors that influence how labor unfolds. They all interact. Understanding them helps you anticipate progress, identify potential issues, and know how to intervene effectively.
The 5 Ps. Okay, break those down for us. Let's start with powers.
Powers basically refers to the forces of labor. In the first stage, the primary power is the uterine contractions. Their frequency, duration, and intensity are what cause the cervix to efface and dilate. Then in the second stage, the pushing stage, the powers are those uterine contractions plus the voluntary pushing efforts of the mother. Effective pushing works with the contractions, directing pressure down along the axis of the pelvis.
Okay, powers. Next is passage.
Passage is the birth canal. It's essentially a curved cylinder made of the bony pelvis and the soft tissues of the cervix, pelvic floor, and vagina. The key part is the true pelvis, the inlet, the mid-pelvis, and the outlet. These bony dimensions are pretty fixed, although the hormone relaxin makes the joints a bit more flexible during pregnancy. But ultimately, the baby has to fit through those bony parts.
Got it. So passage is the route. What about the passenger?
The passenger is primarily the fetus, along with the placenta and membranes. The fetal head is the biggest and least compressible part, so its size and how it presents are really important. Luckily, the fetal skull bones aren't fused yet. They can overlap slightly, a process called molding, which helps the head fit through the passage. As nurses, you'll use the fontanelles, those soft spots and suture lines, to figure out the baby's position during vaginal exams.
Okay, so what aspects of the passenger are most important?
Several things. Fetal lie. Is the baby long ways, longitudinal, or sideways, transverse? Longitudinal is normal, either head down or breech. Transverse makes vaginal birth nearly impossible. Attitude. This is about flexion. Ideally, the baby's chin is tucked to his chest, nice and curled up. This presents the smallest head diameter. Extension, where the head is tilted back, makes passage harder. Presentation. What part is entering the pelvis first? Cephalic, head first, is the most common and usually easiest, especially if the head is well flexed. That's called vertex presentation. Breech, bottom or feet first, happens in about 3–4% of births and carries more risks. Shoulder presentation means a transverse lie, requiring a C-section. Position. This describes how the presenting part, usually the back of the head, the occiput, is oriented within the mother's pelvis. We use 3 letters, like LOA, left occiput anterior. That means the back of the baby's head is on the mother's left side and towards the front. LOA is very common and favorable. Fetal position often changes during labor.
Wow, okay. Lots to consider with the passenger. What's the 4th P?
The 4th P is position, but this time it refers to the maternal position. Encouraging frequent changes in the mother's position throughout labor is so beneficial.
How so?
Well, different positions can improve comfort, help labor progress, and even improve outcomes. Upright positions like walking, standing, squatting, or sitting use gravity to help the baby descend. Side lying, or hands and knees, can help rotate a baby in a tricky position or relieve back pain.
And what positions should be avoided?
Lying flat on the back, or supine, should generally be avoided, as we discussed, because of potential blood vessel compression. Even the traditional lithotomy position with legs and stirrups can restrict pelvic outlet space and isn't ideal for physiological pushing. Your role as a nurse is huge here. Encourage freedom of movement as much as safely possible. Help them find positions that feel good and support progress.
Right, freedom of movement. Okay, last P, psyche.
Psyche. This is the mind-body connection, and it's incredibly powerful in labor. High levels of anxiety, fear, or stress trigger the release of catecholamines, those stress hormones.
And that's bad for labor.
It can be. Catecholamines can actually reduce blood flow to the uterus and inhibit the smooth muscle contractions, potentially slowing down labor progress.
Wow. So a calm environment helps.
Immensely. Feeling safe, informed, calm, and having continuous support, whether from a partner, doula, or nurse, helps the client cope better, reduces stress hormones, and is often linked to better outcomes and higher satisfaction. Part of your job is to assess their expectations, understand their cultural background, provide clear information, advocate for their preferences, and offer that continuous sensitive support. It makes a huge difference.
That's such a powerful framework, those 5 Ps. Okay, so keeping those in mind, how does labor actually start? What are the signs we look for, and what are the stages?
Great question. Before true labor begins, many clients experience premonitory signs. These are signals that the body is getting ready. Things like Braxton Hicks contractions, which might become more frequent or noticeable, lightening, that feeling when the baby drops lower into the pelvis, might feel like easier breathing but more bladder pressure, increased vaginal secretions or discharge, cervical ripening, the cervix starts to soften, thin out. You might see a bloody show, which is the mucus plug mixed with a little blood, as the cervix changes. Sometimes a sudden burst of energy, often called the nesting instinct. Maybe even a small weight loss of 1-3 pounds right before labor starts.
Okay, those are signs it's coming. But how do we know it's really labor? True versus false labor.
That's a critical nursing assessment skill. Lots of things can feel like labor. The only definitive sign of true labor is progressive cervical change, meaning the cervix is demonstrably effacing, thinning, and dilating, opening over time. If there's no cervical change despite contractions, it's considered false labor.
Progressive cervical change. Got it. And once it's truly started.
Once true labor is established, the fetus undertakes a series of maneuvers to navigate the pelvis. We call these the cardinal movements of labor. They happen in sequence. Descent, moving down. Engagement, head enters the inlet. Flexion, chin tucks. Internal rotation, head turns to fit. Extension, head emerges. External rotation or restitution, head realigns with shoulders. And finally, expulsion, baby is born.
Like a little dance down the birth canal.
Exactly. And the labor process itself is divided into stages. The first stage is the dilation stage. It starts with the onset of regular contractions causing cervical change and ends when the cervix is fully dilated at 10 centimeters. This is usually the longest stage.
And that has phases within it.
Yes, traditionally broken into latent phase. From 0 up to about 5 or 6 centimeters dilation. Contractions are usually mild to moderate, maybe irregular at first, then becoming more regular. The client is often sociable, excited, maybe a bit anxious. Active phase. From about 5 or 6 centimeters to 10 centimeters, contractions become stronger, longer, and closer together. Discomfort definitely increases. The client tends to become more serious, focused inward, maybe irritable or needing more support.
Okay, first stage, dilation. What's next?
The second stage is the expulsion stage. This starts at full dilation, 10 centimeters, and ends at the birth of the baby. Contractions continue, often strong. The client typically feels an involuntary, reflexive urge to push or bear down. You'll see the baby's head crowning. Clients often feel a renewed sense of control or purpose during this stage.
Then the baby's born, but it's not over yet.
Not quite. The third stage is the placental stage. This begins right after the baby is born and ends when the placenta is delivered. Usually takes just a few minutes, maybe up to 30. You'll watch for signs the placenta has separated. A firm uterine contraction after the placenta delivers is absolutely vital to clamp down blood vessels and prevent hemorrhage.
Okay, placenta out. Then what?
Then we enter the fourth stage, the recovery stage. This is the immediate postpartum period, typically the first 1 to 4 hours after birth. Your main focus here is monitoring the mother closely for hemorrhage. The uterus should remain firm, usually at or just below the level of the umbilicus. Lochia, the vaginal bleeding, will be dark red, rubra. This is also a really important time for parent-infant bonding and initiating breastfeeding if desired.
And how long does all this take?
It varies hugely. Generally, first-time mothers, nulliparas, tend to have longer labors overall compared to multiparas. Things like epidurals can sometimes lengthen the second stage, the pushing part, because the urge to push might be diminished.
That's a detailed journey. Now, in modern birth settings, technology is everywhere. Fetal monitors, IV pumps. How do we balance using this tech effectively with keeping the experience human and centered on the client?
That's such a crucial point. Technology is invaluable. It helps us identify potential problems early, enhancing safety for both mother and baby. EFM, for example, gives us continuous data. But there's a definite risk of it becoming impersonal. Sometimes the focus shifts too much to the machines, and the client and their family can feel a bit lost in the shuffle, like they're secondary.
So what's our role as nurses in navigating that?
Our role is central. We are the bridge between the technology and the human experience. We need to keep the client and family at the absolute center of care, explain why a monitor is being used, what the sounds mean, interpret the data, but also interpret the person, respect their preferences. If someone desires a low-intervention birth, advocate for that within the bounds of safety. Use technology judiciously, not just routinely. Communicate clearly about risks, benefits, and alternatives so families can make truly informed choices. The machines are tools. They don't replace compassionate, observant nursing care.
Bridge technology and humanity. I like that. Okay, now that we've traced the intricate journey of labor, let's switch gears slightly and talk about something incredibly personal and, well, powerful. Coping with labor pain. You mentioned it's different from other kinds of pain.
Absolutely. Childbirth pain is unique in several ways. First, unlike pain from an injury or illness, it's part of a normal physiological process. It's not usually a sign that something is wrong. Second, it's time-limited. There's an endpoint. Third, it typically comes in waves, with periods of rest in between contractions, which allows the person to regroup. Fourth, it's often purposeful. The discomfort can actually prompt position changes that might help labor progress. And finally, because it's anticipated, clients can prepare for it through education and practice. The profound emotional meaning attached to bringing a child into the world can also significantly increase a person's tolerance for the pain.
That makes sense, but even if it's purposeful, intense pain isn't good, right? Are there adverse effects?
Oh, definitely. Unrelieved, severe pain isn't beneficial. Physiologically, intense pain and the fear that often accompanies it trigger that catecholamine and surge we talked about.
The stress hormones.
Right. That leads to vasoconstriction, potentially increasing uterine muscle tone between contractions, which reduces blood flow to the placenta. It can even make contractions less coordinated and effective. Plus, hyperventilation from pain can cause maternal acid-base shifts, potentially affecting the fetus too.
So less oxygen for baby, maybe slower labor?
Potentially, yes. And psychologically poorly managed pain can lead to exhaustion, difficulty coping, feeling out of control, and can sometimes interfere with bonding or even contribute to postpartum mood disorders or a traumatic birth experience. We also need to remember partners or support people can feel helpless or distressed seeing someone in severe pain.
Okay, so managing pain effectively is important for both physical and emotional well-being. What makes labor pain vary so much between individuals?
So many factors. First, there are different types of pain. In the first stage, it's primarily visceral pain, dull, aching, maybe felt in the lower back or abdomen, coming from the uterus contracting and the cervix stretching. In the second stage, as the baby descends, somatic pain becomes prominent, sharper, more localized pain from the stretching of the vagina and perineum. Then there are physical sources: tissue ischemia, lack of oxygen in the uterine muscle during strong contractions, the actual cervical dilation, pressure on pelvic structures, and that intense stretching.
What makes it feel worse for some than others?
Several things can modify the perception. The intensity of labor, a really fast, precipitous labor, can be overwhelming. How ready the cervix is, an unripe cervix that has to dilate, can be more painful. The baby's position, an occiput posterior or OP baby, often causes intense back labor. The mother's pelvic anatomy, fatigue levels, even interventions, if not explained well, can add to discomfort.
And the psychosocial factors you mentioned earlier.
Hugely important. Culture influences how pain is expressed and perceived. Systemic biases related to race can unfortunately impact care and increase stress. Anxiety and fear definitely amplify pain. Previous birth experiences, especially traumatic ones, play a big role. On the positive side, good preparation through childbirth education, realistic expectations, and a strong, calm support system, continuous labor support from a doula or nurse, is consistently linked to better coping and fewer interventions.
Wow. So as nurses, our assessment needs to be really holistic.
Absolutely. You need to continuously assess both the physiologic aspects and the psychosocial factors influencing their pain experience. Normalize the expression of pain, whatever it looks like for that individual. Validate their experience. Offer comfort measures tailored to them.
Okay, so what are our options? What tools do we have in our toolkit to help clients manage this intense yet purposeful pain?
We generally categorize them into two broad approaches: non-pharmacologic and pharmacologic pain management strategies.
Let's start with non-pharmacologic. What does that involve?
Non-pharmacologic methods focus on promoting coping and comfort, often without aiming to eliminate pain entirely, but rather to manage it. Many clients find these techniques incredibly effective, sometimes exclusively. Think about things like relaxation techniques, conscious breathing patterns, movement and position changes, hydrotherapy using water, massage or counterpressure, application of heat or cold, aromatherapy, music, guided imagery, hypnosis, acupressure. Lots of options.
What are the advantages of using these methods?
There are many. They generally don't have any direct negative side effects on the mother or baby like medications can. They often enhance the client's sense of control and participation. They can leverage the body's own natural pain relievers like endorphins. They're useful throughout labor, even if someone plans on getting medication later or while waiting for an epidural. They can also be really helpful if labor is progressing very quickly and there isn't time for medication, and they don't require complex medical procedures.
Any limitations?
Well, for some individuals, especially with very intense or prolonged labor, non-pharmacologic methods alone might not provide sufficient relief. The effectiveness can also depend a lot on preparation and support.
How do they actually work, like the science behind it?
A lot of it relates to the gate control theory of pain. The idea is that nerve pathways can only carry so many signals at once. Using pleasant sensations like massage, warmth, or pressure sends signals along large nerve fibers, which can effectively close the gate in the spinal cord, blocking some of the pain signals traveling on smaller fibers from reaching the brain. Mind-body techniques like relaxation, focused breathing, and imagery work by reducing tension, decreasing the perception of pain, promoting a sense of calm, and enhancing self-efficacy, the belief in one's ability to cope. Education itself reduces fear of the unknown, which lowers stress hormones.
So preparation is key.
Definitely. Prenatal education is ideal, so clients and their partners can practice techniques beforehand. But even if they haven't practiced, you can teach simple techniques during early labor, between contractions. Encourage them to try different things, see what works best for them right now, and definitely involve partners or support people in providing these comfort measures.
What are some of the most effective techniques you see used?
Relaxation is really foundational. When the body's tense, pain feels worse, and it can even interfere with contractions. Helping the client consciously release tension, maybe through guided imagery, progressive relaxation, or simple verbal cues, improves uterine blood flow, can make contractions more efficient, lowers pain perception, and helps the body open up for fetal descent.
And the environment plays a role here.
Huge role. One of the most critical nursing actions is shaping the environment to support relaxation and oxytocin release, the love hormone that drives labor but is inhibited by stress. Dim lights, quiet atmosphere, minimizing interruptions, ensuring privacy, these things matter. Speak calmly, use brief, clear, reassuring phrases. Lowering those catecholamines is key.
What about things like touch?
Cutaneous stimulation techniques are very popular. Simple massage, like effleurage, light stroking on the abdomen, can be soothing and boost endorphins. Counterpressure is fantastic for back labor, often caused by an OP baby. Applying firm, steady pressure to the sacrum, or doing a double hip squeeze during contractions, can provide significant relief. Let the client guide you on the amount of pressure. Thermal therapy, warm packs on the back or abdomen, cool cloths on the forehead or neck can be very comforting. Some find relief with acupressure, applying pressure to specific points, though this is more based on preference and usually requires some training.
You mentioned hydrotherapy.
Yes, hydrotherapy, using a warm shower or immersing in a tub, is wonderful for many. The buoyancy reduces pressure, the warmth relaxes muscles. Studies show it's associated with less need for pharmacologic analgesia, potentially shorter labors, and higher satisfaction. Facilities have specific criteria for who can safely use tub immersion, though.
And the mental strategies.
Mental strategies like guided imagery, visualizing a peaceful place, using mantras or affirmations, or formal techniques like hypnobirthing can be very powerful for focusing the mind away from the pain. Even if they haven't practiced, you can coach simple visualization or focusing techniques.
Breathing techniques seem like a cornerstone, too.
They are. Breathing techniques serve multiple purposes. They provide focus, ensure adequate oxygenation, and promote relaxation. Start with a deep cleansing breath at the beginning and end of each contraction as a signal. The default is often slow-paced breathing. Breathing in slowly through the nose and out slowly through the mouth, about half the normal rate. They might need to speed it up slightly at the peak of a strong contraction. It used to be called modified pace, but the focus now is just adjusting the slow pace as needed.
What if they start pushing too early?
If they feel the urge to push before the cervix is fully dilated, pattern breathing like light, open mouth blowing it like blowing out a candle can help resist that urge temporarily. And if someone starts hyperventilating, model slower breathing for them, maybe breathe with them, coach them back into a pattern.
And breathing during the actual pushing stage.
For second stage pushing, we now emphasize physiologic pushing. This means following the client's spontaneous urge to push rather than rigidly directed pushing. It's usually open glottis, no prolonged breath holding or straining like the Valsalva maneuver, which can tighten the pelvic floor. Encourage maybe 3 to 4 shorter pushes, about 6-8 seconds long per contraction, timed with their urge. Coaching them to make low, deep grunting sounds can actually help relax the pelvic floor. With an epidural, sometimes laboring down, letting the baby descend passively for a while before active pushing is beneficial. Your role is to synchronize coaching with their efforts.
That's a fantastic overview of non-pharmacologic options. Now, what about pharmacologic pain management?
Right. Many clients choose or require pharmacologic pain management. It's essential that nurses provide clear, unbiased information about the different methods available, their effectiveness, potential side effects for both the client and the fetus, and the implications for labor. Informed consent is critical.
What are the main categories?
Generally, we have systemic medications that circulate throughout the body, like opioids or nitrous oxide. Then there's regional anesthesia or analgesia, which numbs a specific area, like epidurals, spinals, or pudendal blocks. And finally, general anesthesia, which causes unconsciousness, typically reserved for emergencies.
Are there special things to consider when giving meds during pregnancy and labor?
Absolutely. A few key points. Placental transfer. Almost all systemic drugs cross the placenta to some degree. The timing of administration relative to birth and the dose are crucial considerations, especially regarding potential effects on the newborn, like respiratory depression. Physiologic changes. Pregnancy alters cardiovascular, respiratory, and other systems. This can affect how anesthetics spread, increase the risk of aspiration, and potentially alter sensitivity to drugs. Comorbidities. Conditions like obesity, hypertension, or preeclampsia might limit options or require dose adjustments. Interactions. Always assess for potential interactions with herbal supplements, prescribed medications, or substance use.
So thorough assessment first is key.
Critical.
Huh?
Before any medication, review the client's history, allergies, current meds, gestational age, labor status, vital signs, and fetal heart rate pattern. Discuss the risks and benefits clearly, answer questions, and ensure informed consent is obtained according to policy.
What about effects on the baby?
Medications can affect the fetus directly, for example, opioids causing decreased FHR variability or respiratory depression after birth, or indirectly. A major indirect effect is maternal hypotension, often seen with epidurals or spinals. If the mother's blood pressure drops significantly, placental perfusion decreases, which can lead to fetal hypoxia and acidosis, reflected in FHR changes like late decelerations.
So close monitoring after medication is essential.
Absolutely. After any systemic analgesia or regional anesthesia, you need to monitor maternal vital signs, especially BP and the FHR pattern, very closely. Be prepared to intervene quickly if you see decreased variability, decelerations, or a significant drop in maternal BP. Remember those interventions.
Okay, let's talk specific meds. What about systemic options?
Two main ones currently. Nitrous oxide. This is a 50-50 mix of nitrous oxide and oxygen, self-administered by the client via a mask they hold themselves. It provides mild analgesia and reduces anxiety. It works very quickly, but also clears the system quickly once they stop inhaling. Main side effects are potential nausea or dizziness. It requires a special delivery system with scavenging to remove exhaled gas. Opioid analgesics. Drugs like fentanyl, morphine, nalbuphine, or butorphanol are often given IV. They reduce the perception of pain, but don't eliminate it completely. Big drawback. All cross the placenta. Giving them too close to birth significantly increases the risk of neonatal respiratory depression. So timing is crucial. Generally try to avoid within 1 to 2 hours, maybe even longer depending on the drug, of anticipated birth. Also avoid mixed agonist-antagonists like nalbuphine or butorphanol in clients with opioid dependence, as they can trigger withdrawal.
And if there is respiratory depression?
Naloxone, Narcan, is the opioid antagonist used to reverse respiratory depression in both the mother and the newborn if needed. Keep it readily available. But remember, its duration of action is often shorter than the opioids, so repeat doses might be necessary. and using it in an opioid-dependent person or newborn can precipitate acute withdrawal, which is dangerous.
Okay, that covers systemic. What about regional options, the ones that numb specific areas?
Right. Regional pain management is very popular because it can provide excellent pain relief while allowing the client to remain awake and participate. Local infiltration. Injecting anesthetic directly into the perineal tissues, usually done just before an episiotomy or for repair after birth, numbs to that small area. Pudendal block anesthetizes the lower vagina and perineum by injecting near the pudendal nerve, good for the pushing stage in birth or for repairs. Doesn't relieve contraction pain. Epidural block. This is the most common and often most effective method for labor pain relief. A catheter is placed in the epidural space in the back, and anesthetic analgesic medication is infused continuously or intermittently. The client remains awake and aware.
What are the downsides of an epidural?
Potential risks include maternal hypotension, that's a big one, potential bladder distension requiring catheterization because the sensation to void is lost, sometimes incomplete relief or hot spots, itching if opioids are used, fever, and rarely a dural puncture headache if the needle goes too far. It can sometimes slightly prolong the second stage of labor. Requires vigilant nursing monitoring.
What's our role before and after an epidural?
Key nursing actions before. Ensure fee access is established. Preload with a bolus of IV fluid, typically 500 to 1,000 millirel, to counteract potential hypotension. Get baseline vital signs in FHR. Assist with positioning after. Monitor blood pressure in FHR frequently, usually every 5 minutes for the first 15-20 minutes, then per policy. Assess sensation level. Monitor for side effects. Manage bladder care. Spinal subarachnoid block. A single injection of anesthetic directly into the spinal fluid provides rapid, profound numbness, but for a shorter duration than an epidural, often used for scheduled C-sections. Similar risks to epidural, especially hypotension and potential spinal headache. Combined spinal epidural, CSE, often called a walking epidural, though walking isn't always feasible. Combines the rapid onset of a spinal block for initial relief with the placement of an epidural catheter for ongoing infusion. Or axial opioids. Sometimes opioids like fentanyl or morphine are added to the epidural or spinal anesthetic. They enhance pain relief but can cause side effects like nausea, itching, pruritus, and importantly, delayed respiratory depression hours later, which requires careful monitoring.
Okay, one more. General anesthesia.
General anesthesia is rarely used for vaginal births nowadays. It's typically reserved for emergency C-sections where regional anesthesia isn't possible or practical, or for certain complications. It involves inducing unconsciousness and loss of protective reflexes.
How's riskier?
It does carry more risks for both mother and baby. The mother. Risk of failed intubation, aspiration of stomach contents, hence being MPO, and other anesthetic complications. For the baby, significant respiratory depression because the anesthetic agents cross the placenta rapidly. Requires a highly coordinated team approach, pre-oxygenation, potentially cricoid pressure during intubation, and ensuring the neonatal resuscitation team is present before anesthesia induction for a C-section.
That's a really thorough look at pain management options. Okay, shifting focus again. While comfort is vital, the other critical piece of our intrapartum care is constantly monitoring the fetus. How is the baby tolerating this whole process? This is where fetal monitoring comes in as our window to their well-being.
Exactly. The whole goal of intrapartum fetal surveillance is to assess fetal oxygenation and prevent injury from hypoxia by recognizing early warning signs reflected in the fetal heart rate patterns and responding appropriately.
What are the main ways we monitor the baby?
We have both low-tech and high-tech approaches. Low technology. This is intermittent auscultation, IA, using a handheld Doppler device or even an old-school fetoscope to listen to the fetal heart rate periodically, usually before, during, and after a contraction. This is typically accompanied by palpating the uterus to assess contraction strength and resting tone. IA is appropriate for low-risk pregnancies where the client prefers less intervention. A key skill here is reliably distinguishing the FHR from the mother's pulse. High technology. This is electronic fetal monitoring, EFM, which provides a continuous printout or screen display of both the FHR and uterine activity, UA. EFM is generally used for higher-risk pregnancies, induced or augmented labors, when concerning patterns are detected with IA or based on client preference or facility policy.
And EFM can be external or internal.
Correct. External monitoring uses two belts around the abdomen. One with an ultrasound transducer, Doppler, to pick up the FHR, and the other with a pressure sensor called a tocodynamometer, or TOCO, placed over the fundus to detect uterine contractions. It's non-invasive. Many units now have wireless telemetry systems allowing more freedom of movement. Internal monitoring requires ruptured membranes and some cervical dilation. A fetal scalp electrode, FSE, is a small spiral wire attached directly to the fetal scalp for a precise FHR reading. An intrauterine pressure catheter, IUPC, is a thin tube inserted into the uterus alongside the fetus to measure contraction intensity and resting tone in millimeters of mercury, NRSG. Internal monitoring gives more accurate data, especially if external signals are poor, you're still with obesity. There are contraindications, like avoiding FSE with maternal infections like HIV or active herpes, or known placenta previa.
So how do nurses decide which method to use?
It's based on a combination of factors: assessed risk level, stage of labor, client preferences, and facility guidelines. Regardless of the method, the goals are the same. Evaluate fetal oxygenation status, identify concerning changes promptly, initiate corrective interventions when needed, improve communication among the care team, and support shared decision-making with the family.
You mentioned interventions. If we see concerning FHR changes, what's the immediate nursing response?
The immediate response usually involves implementing what are often called intrauterine resuscitation measures. A common mnemonic to remember the key steps is those. T. Turn or reposition the client, usually to the left or right lateral position, to relieve potential cord compression or improve placental perfusion. H is hydrate with an IV fluid bolus to increase maternal blood volume and placental perfusion. O. Oxygenate by administering supplemental oxygen to the mother via non-rebreather mask, usually 8 to 10 element, to maximize fetal oxygen supply. S. Stop oxytocin, pitocin infusion if it's running, as it increases contraction frequency strength, potentially reducing resting time and fetal oxygenation, or at least titrate it down. E. Evaluate and reassess the FHR response promptly. Notify the provider, and be prepared to expedite delivery if these measures don't resolve a persistent non-reassuring pattern.
Those: turn, hydrate, oxygenate, stop oxytocin, evaluate, expedite. That's a really useful action-oriented mnemonic. Okay, let's back up a bit. How exactly does oxygen get to the baby, and what can go wrong along that pathway to cause these FHR changes in the first place?
Understanding the fetal oxygenation pathway is fundamental. Think of it as a chain. Oxygen comes into the mother's lungs, gets circulated by her heart and vessels, perfuses the uterus, crosses the placenta, travels through the umbilical cord, and finally reaches the fetus. An interruption anywhere along this chain can impair oxygen delivery. If the impairment is significant or prolonged, the fetus progresses from normal oxygenation, normoxia, to reduced oxygen, hypoxemia, to insufficient oxygen in the tissues, hypoxia, potentially leading to metabolic acidosis, buildup of acid due to anaerobic metabolism, and finally metabolic acidemia, acidosis reflected in the blood. FHR patterns are often the earliest indicators of these interruptions.
Okay, break down the key points in that chain. Uterus and placenta.
The uteroplacental circulation is critical. The placenta acts as the fetal lungs, facilitating gas exchange. Maternal blood flows into the placental spaces via spiral arteries. Here's the key. During a uterine contraction, this maternal blood flow into the placental space essentially stops or dramatically slows down.
Because the muscle is squeezing those vessels.
Exactly. So if contractions are too strong, too frequent, or if the uterus doesn't relax adequately between them, high resting tone, the time for oxygen exchange is reduced. The fetus has reserves, but prolonged or excessive uterine activity can deplete them. The fetus tries to compensate by shunting blood flow towards vital organs, the brain, heart, and adrenal glands, but this can only go on for so long.
And the umbilical cord.
The fetal placental circulation relies on the umbilical cord. It normally contains 2 arteries carrying deoxygenated blood away from the fetus and 1 vein carrying oxygenated blood to the fetus, all cushioned by Wharton's jelly. If the cord gets compressed, maybe it's wrapped around the baby's neck or pinched between the baby and the pelvis, or there's low amniotic fluid, blood flow is obstructed. This is a common cause of variable decelerations in the FHR. The fetus also has special circulatory shunts that bypass its lungs and liver in utero, directing oxygenated blood efficiently.
What actually controls the fetal heart rate itself?
FHR regulation is complex, involving both extrinsic factors, things outside the fetus like maternal oxygen levels, uterine blood flow, cord integrity, and intrinsic factors within the fetus. The main intrinsic regulator is the autonomic nervous system, ANS, which has 2 branches. The parasympathetic nervous system, think P for peaceful or pillow, primarily acts via the vagus nerve. It generally slows the FHR and promotes variability. It's dominant in a well-oxygenated, non-stressed fetus, helping regulate the baseline rate. The sympathetic nervous system, think S for stressful or speedy, is the fight-or-flight system. It increases the FHR and cardiac output, helping maintain blood flow to vital organs during periods of stress or mild hypoxia. Accelerations in FHR are often sympathetic responses.
So it's a balance between those two.
Exactly. A healthy, well-oxygenated fetus shows good interplay between the parasympathetic and sympathetic systems, resulting in moderate FHR variability. Other intrinsic factors include baroreceptors, detect blood pressure changes, chemoreceptors, sensitive to oxygen, carbon dioxide, and acid levels, and hormonal influences like catecholamines released during stress, which increase FHR and shunt blood.
You keep mentioning variability. Why is that so important?
Baseline FHR variability is arguably the single most important indicator of fetal oxygenation status on an EFM tracing. It reflects the push and pull between the sympathetic and parasympathetic nervous systems. Moderate variability, amplitude range of 625 beats per minute, tells us that the pathway from the brain to the heart is intact, and crucially, that the brainstem is well oxygenated. It's a very reassuring sign. Reduced or absent variability, minimal is EFI BPM, absent is undetectable, is concerning. It suggests the ANS isn't functioning properly, which could be due to fetal sleep cycles or medications, but it can also be a significant sign of fetal hypoxia and acidosis, or CNS depression. Absent variability, especially if combined with decelerations, requires prompt investigation and intervention.
That makes variability a really key thing to watch and reinforces why those interventions are so important if we see changes.
Precisely. Those interventions are all aimed at improving or restoring oxygen delivery along that pathway.
Okay, this brings us squarely to interpreting those EFM strips. It can look like a lot of squiggly lines. How do we approach it systematically and use standardized language so everyone on the team is on the same page?
Absolutely essential. We use the standardized definitions agreed upon by organizations like NICHD, National Institute of Child Health and Human Development, for systematic interpretation. This involves looking at several components: baseline fetal heart rate, the average FHR over a 10-minute window, excluding accelerations and decelerations. Normal is 110, 160 BPM. Below 110 is bradycardia, above 160 is tachycardia. Remember, preterm fetuses often have a slightly higher baseline due to sympathetic dominance, while term fetuses might be lower due to parasympathetic maturity. Baseline variability. As we just discussed, this is the fluctuation or waviness of the baseline FHR. We classify it by amplitude: absent, undetectable; minimal FA-BPM; moderate, 625 BPM, or marked 25 BPM. Again, moderate variability is the goal. It's highly predictive of the absence of fetal metabolic acidemia at that point in time.
What about a pattern that looks like a sine wave?
A true sinusoidal pattern is a specific, visually distinct pattern, a smooth, undulating sine wave with a frequency of 3 to 5 cycles per minute, lasting for at least 20 minutes, with absent variability and no accelerations. This is rare but ominous, often associated with severe fetal anemia, for example from Rh isoimmunization or fetal hemorrhage, or profound hypoxia. It requires immediate intervention and likely urgent delivery. Be careful not to confuse it with pseudosinusoidal patterns, which can be caused by medications or fetal thumb sucking and are usually temporary.
Okay, baseline rate and variability. What about the ups and downs, the accelerations and decelerations?
These are periodic and episodic FHR patterns. Periodic patterns are those associated with uterine contractions. Episodic patterns occur independently of contractions. We also look at whether decelerations are recurrent, occurring with 50% of contractions in a 20-minute window, or intermittent.
This sounds like where VEAL CHOP comes in handy.
Exactly. The VEAL CHOP app mnemonic is a fantastic tool, widely used to help associate common FHR patterns with their likely underlying causes and guide initial actions. Variable decelerations relate to cord compression. These look like abrupt drops in FHR, 15 BPM below baseline, lasting 15 seconds but 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name variable. They're the most common type of deceleration seen in labor. Nursing response. Change maternal position. Consider amnio infusion if ordered, infusing fluid into the uterus to cushion the cord. Apply those principles if severe or recurrent. These look like abrupt drops in FHR, 15 BPM below baseline, lasting 15 seconds but 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name of variable. They are the most common type of deceleration seen in labor. Nursing response. Early decelerations relate to head compression. These look like abrupt drops in FHR, 15 BPM below baseline, lasting 15 seconds but 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name variable. They are the most common type of deceleration seen in labor. Nursing response. These are gradual, shallow decreases in FHR that mirror the contraction. The lowest point, nadir of the deceleration, occurs at the same time as the peak of the contraction. They are benign, considered a normal response to head compression as the baby descends, and require no specific intervention. Just document them. These look like abrupt drops in FHR, 15 BPM below baseline, lasting 15 seconds but 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name variable. They are the most common type of deceleration seen in labor. Nursing response. Accelerations relate to, meaning normal fetal oxygenation. These look like abrupt drops in FHR or 15 BPM below baseline lasting 15 seconds but 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name variable. They are the most common type of deceleration seen in labor. Nursing response. These are abrupt increases in FHR above the baseline, 0.15 BPM increase lasting 0.15 seconds for term fetuses. Accelerations, whether spontaneous or with fetal movement, are highly reassuring signs of fetal well-being and adequate oxygenation. We like seeing these. These look like abrupt drops in FHR, 0.15 BPM below baseline, lasting 15 seconds to 2 minutes. Their shape, depth, and timing relative to contractions can vary, hence the name variable. They are the most common type of deceleration seen in labor. Nursing response. Late decelerations relate to placental insufficiency, uteroplacental insufficiency. These are also gradual decreases in FHR, but their nadir occurs after the peak of the contraction, and the recovery back to baseline occurs after the contraction has ended. This delayed timing suggests the fetus isn't getting enough oxygen during the contraction and takes longer to recover. Recurrent late decelerations are concerning, especially if accompanied by minimal or absent variability, as they indicate impaired placental function. Nursing response. Implement those interventions immediately. Notify the provider and prepare for potential expedited delivery if they persist and don't resolve.
VEAL CHOP. Variable cord, early head, acceleration, late placental. That really helps clarify things. What about a deceleration that lasts a long time?
That's a prolonged deceleration, defined as a decrease in FHR from baseline of 15 BPM, lasting 2 minutes but 10 minutes.
Right.
If it lasts 10 minutes or more, it's considered a change in baseline rate. Prolonged decelerations reflect a more significant interruption in fetal oxygenation, maybe due to maternal hypotension after an epidural, uterine tachysystole, cord prolapse, or placental abruption. They always require immediate evaluation, implementation of those corrective measures, and preparation for expedited delivery if the cause can't be quickly identified and corrected.
So, VEAL CHOP helps us connect the pattern to the likely cause and guides our initial actions, especially remembering those.
Precisely. It's about pattern recognition linked to physiology and action.
Now, to make sure everyone is communicating clearly about the overall fetal status, especially when talking to providers or documenting, isn't there a categorization system?
Yes, the NICHD also established a 3-tier system for FHR pattern categorization. This helps standardize interpretation and communicate the level of concern. Category 1, normal. These patterns are strongly predictive of normal fetal acid-base status at that time, includes normal baseline rate 110 to 160. Moderate variability may have accelerations, may have early decelerations, but no late or variable decelerations. Think of this as the green light. Everything looks good. Continue routine monitoring. Category 2, indeterminate. This is the largest category and includes all patterns not classified as Category 1 or 3. They are not clearly predictive of abnormal fetal acid-base status, but they require continued surveillance and evaluation. Examples include tachycardia or bradycardia with preserved moderate variability, minimal variability, marked variability, absence of accelerations after fetal stimulation, recurrent variable decelerations with moderate variability, prolonged decelerations, 2 minutes but 10 minutes, recurrent late decelerations with moderate variability. Think yellow light, proceed with caution, watch closely, consider those interventions, communicate findings, reevaluate frequently. Category 3, abnormal. These patterns are predictive of abnormal fetal acid-base status at that time and require prompt evaluation and intervention. Includes absent baseline variability plus any of the following: recurrent late decelerations, recurrent variable decelerations, or bradycardia. Also includes a sinusoidal pattern. Think red light, stop, and act now. Requires immediate evaluation, implementation of those, efforts to resolve the pattern, and likely expedited delivery if it doesn't resolve quickly.
That system seems really helpful for standardizing risk assessment and communication. Category 1 is good, Category 3 is bad, Category 2 needs watching.
That's the essence of it. It provides a common language.
Briefly, you also mentioned assessing uterine activity alongside FHR.
Yes, you can't interpret FHR patterns without considering uterine activity. UA. We use standardized definitions here too. Frequency, how often contractions occur, start of one, start of the next. Duration, how long each contraction lasts, start to end. Intensity, strength of the contraction, usually described as mild, moderate, or strong by palpation, or measured in mmHg with an IUPC. Resting tone, how relaxed the uterus is between contractions, soft by palpation, or 20-25 millimeters G with IUPC. Crucially, relaxation time, the time from the end of one contraction to the beginning of the next. This needs to be adequate for fetal reoxygenation. Crucially, relaxation time. Normal UA is generally defined as FA5 contractions in a 10-minute period, averaged over 30 minutes. Crucially, relaxation time. Tachysystole is defined as 5 contractions in 10 minutes, averaged over 30 minutes. This is concerning because it reduces resting time, regardless of whether FHR decelerations are present. If oxytocin is infusing, it usually needs to be decreased or stopped if tachysystole occurs.
Okay, so assess FHR and UA together. Is there an overall model for managing concerning FHR patterns?
A helpful framework often taught is the intrapartum management decision model, sometimes called the ABCD approach. A. Assess the oxygen pathway and identify the likely cause of the FHR change. Using VEAL CHOP helps here. Also, assess the overall clinical picture. B. Begin corrective measures. Implement those interventions. C. Clear obstacles to rapid delivery. If the pattern is concerning and not resolving, start thinking ahead, notifying necessary personnel, provider, or team PEDs. Ensure IV access, etc. D. Determine the delivery plan. Based on the response to interventions and the overall situation, decide if expedited delivery, operative vaginal birth or C-section, is necessary.
ABCD. Assess. Begin corrective measures. Clear obstacles. Determine delivery plan. Logical flow. Any key lab values we should keep in mind during labor?
Just briefly, knowing baseline hemoglobin and hematocrit is important for assessing tolerance to blood loss. White blood cell count, as mentioned, normally increases in labor. Platelet count is crucial, especially before placing an epidural or spinal, as low platelets increase bleeding risk.
Fantastic. Okay, let's wrap this deep dive up. So we've really journeyed through the whole intricate process of labor, the physiology, the 5 Ps, the stages. We explored the many facets of pain management, both non-pharmacologic support and pharmacologic options. And we gained a solid framework for interpreting those vital fetal monitoring patterns using standardized language and interventions like those. It's clear that your role as a nursing student, and soon as a nurse, is absolutely central. You're not just reading monitors or giving meds. You're assessing, supporting, educating, anticipating, and advocating for the birthing client and their family every step of the way. Recognizing those early warning signs, using interventions like those effectively, and collaborating smoothly with the whole healthcare team, these are paramount for ensuring safety and hopefully a really positive birth experience.
Absolutely. This deep dive really highlights the power we have when we integrate that deep physiologic knowledge with evidence-based, compassionate nursing interventions. It leads me to a final thought, maybe a question for you to ponder as you move forward in your careers. In an era of increasing technology in childbirth, how do we, as nurses, continue to skillfully integrate these valuable tools like EFM or advanced pain management techniques while always maintaining truly individualized, human-centered care? How do we ensure that every birth is not just safe, which is a baseline, but is also remembered as an empowering, respectful, and positive experience for the client and their family? Something to think about.